Okay. Welcome, everybody. Thank you for your patience.
You opened it up, and I'm like, do control.
Please.
Okay, this is a touch. I'm going to try to move, but I'm sorry you guys are going to be kind of looking back on me, but
That's okay, they can move their chairs around.
Okay, so yeah, welcome to the portrait. I'm going to have a couple of PowerPoint slides that in theory would be part of this presentation, but given that we are a little tight on time, I'm going to skip through the overview since you have all read the portrait. I know you have all read the overview of the portrait, so we are going to assume that and move on. But we want to lay the groundwork for the discussion that unfolds today. So to do so, we just kind of want to remind you of the landscape of some of the the trans health disparities that are kind of form the background of our portrait. Trans people experience higher rates of mental distress, substance use, homelessness, sexual, verbal, and physical assault, and higher rates of suicide. Trans people are also far more likely to experience traumatic events and violence throughout their life. At the same time, trans people are more likely to be uninsured and have had negative experiences with healthcare professionals that impact their use of healthcare. And 1 in 5 trans people report having been denied access to care. Trans people of color are even more likely to report being denied care. These are facts of the landscape of trans healthcare. But our portrait is asking what some of the reasons for those health disparities are, but from a slightly different angle. So to kind of get us warmed up and to get us started, we are actually going to move into an activity that kind of asks us to collectively map what some of the most common explanations are for those health disparities. I'm going to hand it over to my colleague.
So really quickly, you don't have a lot of time, we're going to go fast a bit. But when you think of some of the common explanations for trans health disparities, what do you think about?
From their perspective or somebody?
From anybody. When you think about mainstream discrimination, great.
Like a societal.
Yeah, what you know, yeah.
Lack of providers.
Providers what?
Who are
Information?
knowledgeable.
Of knowledge, okay.
She said lack of.
Right.
Yeah.
Stereotyping?
Stereotyping, great. Anything, what was that? Shame. Sorry, shame.
Lack of access in whatever community they're in, like maybe it's more in urban centers.
Anything else? Fear, great.
Insurance coverage.
Insurance. All right, these are great. We could come up with way more. Let's stop there.
Normally, this would take a little bit longer. That's okay, great.
But part of what we're trying to do is get us to see kind of the picture from 2 different angles. We have a set of facts, the trans health disparities that we know. We have a set of kind of some of these larger explanations that we have for those trans health disparities. We're going to take one piece of that puzzle and look at medicalization as a social issue that in a lot of ways underpins a lot of what we already have kind of mapped out here. And the goal of the portrait is to facilitate knowledge or understanding of the concept of medicalization through the analytical skills that disability studies provide, to increase understanding of medicalization as a social issue. And I think this is kind of key to the portrait that impacts trans identity and trans experiences with healthcare, and to provide students with tools to critically understand how the tools that are used in trans health, such as diagnosis, cure, and treatment, can actually lead to some of those disparities, not just that those are tools to eliminate those disparities. It's kind of a both-and scenario, and this is what we are kind of the lens with which we have assembled this work. And to kind of get us started on the overview of disability studies, as you read in the portrait overview, disability studies is an interdisciplinary field of research, focuses on social, cultural, historical, political, and economic structures that impact disabled people's lives, experiences, and futures. It understands as a field that disability is a source of knowledge and creative expression. And And it critiques, again, as a field, not it, the singular field as a whole, critiques the singular view of disability as a medical problem to be solved through individual intervention within individuals' bodies and minds. So in some ways, we kind of describe disability studies as shifting the analytical focus from an individual to the context surrounding the individual, to look at that kind of interaction. And medicalization is a concept that different disciplinary backgrounds have sort of taken a piece of. Medical sociologist Peter Conrad defines medicalization as a process by which non-medical problems come to be defined and treated as medical problems, usually in terms of illness or disorder. This is kind of, I think, a mobile definition that moves across context. But disability studies specifically, I would argue, extends this understanding to view medicalization as the larger processes that construct non-normative bodies and their minds into problems that require medical or rehabilitative intervention targeted within those individual bodies or minds. So it's not just that this is a medical problem and this isn't. The medicalization says it's the process by which non-medical problems come to be seen as medical, but it's the entire process of naming something a medical problem. And that this, part of the impact of that is a narrowing of the lens with which we view problems of the body and mind. The distillation of experiences to only being to only or predominantly individual problems that then direct the intervention into individual bodies or minds. This is the part when I'm teaching where I usually say, are there any questions?
There could be.
So you read for the portrait some selections from Eli Clare's book, Brilliance in Perfection. We kind of picked one piece of that to start our discussion today. Clare offers us the concept of ideology of cure as a way to describe how medicalization functions. Medicalization helps shape the belief that all sick and or disabled people require, desire, and should actively be working toward a cure. This belief, in turn, shapes much of the systems and structures that emerge to manage disabled bodies and minds, including within medicine. Clare describes all of this as happening kind of within medicine, but also in a broader social context, an ideology of cure, or a set of ideas, a set of beliefs. That structure assumptions that people with disabilities need and want a cure, and that creates a kind of imagined trajectory from diagnosis to treatment to cure. And even if this is not always a straightforward path, it is seen as one that is objective, predetermined in its kind of desirability, and a singular path, where cure is the end point. But Clare is offering us something different. He is complicating these concepts in what we read. So we actually want to start off with the discussion of how does he understand cure? How does the text complicate this health and illness binary? And how does that relate to gender? How does he problematize the gender binary through this discussion of the ideology of cure? So that was kind of a lot. So let's actually start with just point one.
I can sit for now.
Should I sit? That would be nice. I'm going to move to the table now for a discussion, on which I will return. We're recording. I want to
Carrie has thoughts. Tell us your thoughts, Carrie.
Well, in the excerpt we read, in order to be a cure, there needs to be a diagnosis. And so first there's an identification of the problem, and then he takes us through a process of how diagnosis is culturally constructed and shifting. And so even at the point of imagining a cure in the future, first there has to be an analysis of the problem.
The problem. And it's, I think, key that he's talking us through the ways through even the specific diagnostic category changes over time, right? And so we get to see some of that, that reference of changing categories becomes the ways that one of the ways he destabilizes that initial process.
I think that was striking to me was the idea of power of the diagnosis and how that then disempowers the patient, because then you're looking to the doctor to identify, and it's almost like then the doctor's almost claiming it and the patient is following along. It gives me chills just to think about, how disempowering that is and how powerful, that we think about the power of the physician in the context of medicalizing something, and then how quickly the patient's mind goes on a train of thought that the provider is really the driver for. So that was something very striking.
Mm-hmm.
So this reading, first of all, is just brilliant. But it reminds me so much of Charles Rosenberg in the 80s, talking about how we frame disease and the moment of diagnosis as sort of the naming, right? And what does that do? The generative nature of the naming. And that people who have maybe something that's going on in their body and can't figure it out, search. They go from doctor to doctor to doctor, and they get very frustrated because they want the name, right?
Yeah.
Because it opens up what Shay was talking about, and this is what he says. First of all, it opens up insurance payments, because you must have a diagnostic, you must have a DRG, is that right? To get reimbursed, right? And it opens up sort of social acceptance or non-acceptance in a lot of ways. But it's sort of this panoply of what it does. It's a door that opens up both things that you might need, but also things that could be really destructive. And so I think Eli is raising this sort of in a more contemporary way, and definitely, more beautifully, I think, than Rosenberg. But
But that's the piece I think that's really special about it, is that it's not just what's productive. I think that at the same time as he's showing, that's what I think, especially the first page of this, to me, every time I read it, I start tearing up, because it's a very, the contrast of both the positives and the negatives at the same time of diagnosis is what I think he does a really beautiful job of showing, that it can be both and, right? And that to me is a really interesting piece, and also relates to this concept of the cure, because, the diagnosis piece is important. I know I'm not supposed to be talking as part of it, but there's only there's only two of us, so we have to consider it. Anyway, but I think that piece is what's really interesting, is that you have to have the diagnosis to get to a cure, and since he's disrupting the diagnosis, he's also disrupting the cure, which I think is really beautiful. So.
I too was really struck by the power of naming something, and for me it just made me think of other traditions. They're so influential in our own Western American culture, where to name something is to have authority over it. I name my child, I have authority over my child, and hopefully that's an authority of service. But still, there's a power there, when we can put a name to something, and when it's just the idea of a label, being labeled and by a diagnosis, and it can make feel like somebody has authority over them.
And
Can I pipe in? I said I wouldn't talk, and I can't help it.
we know you, Rebecca. Go ahead, Rebecca.
Oh, I love everything everyone said so far, and I just wanted to add something that I've read this text a couple of times, and something that came out because of the way you chose the excerpts. I thought they were really good excerpts. That the therapist, when Claire goes to the therapist and is really trying to use professionals to get what he, as a patient coming with a lot of experience from a community of citizen scientists, knowing what he needs. He's trying to use the professionals for what he needs, encounters a professional whose entire set of perceptions are shaped by diagnosis. And that just really crystallized for me that on the one side, you have Claire who knows that I think, Allie, you said that the idea of cure is mobile, right? And Claire said it's embedded in text-based culture and science, but the therapist sees it as fixed. And that moment there, and it's sort of the end of the story because it feels like it all just shut down. But, it seems like Claire was just like looking for someone who wouldn't cause him too much distress, right? And there's like that management of how much he has to perform the diagnosis in order to get access to the care, but that kind of opposition that can happen around medical education is just crystallized in that moment.
But in that way, Rebecca, Claire, or whomever, also is powerful, right? They're, in some ways, I mean, in the hierarchy of medicine, no, but by using the medical system for what he needs, there's a certain amount of empowerment, I think.
Survival, both.
Survival, yeah. Right.
So, but what I keep thinking about is the importance of the patient knowing about the need to use the medical industrial complex that way, because it's hard not to personalize this because it's so beautifully personally written. I had this memory of when I went to go get some therapy after I had lost my partner, and I went and I was in a good place, I was doing fine, and I needed to get some, counseling. And I had this great session with the therapist, and after the session, he wrote a diagnosis down, and he told me it was for the purposes of reimbursement. But the diagnosis that he chose to write down was like attachment disorder. And he just did it in this very flippant way. I'm just going to write down that you have attachment disorder because I need to get insurance. And I was so insulted and so hurt, and so it was really uncomfortable to be diagnosed so flippantly and to be told that I had this disorder that I didn't feel that I had after one session. It was very, very hurtful, and so I never went back to him. And I think that if I had known more ahead of time, if he'd said from the very beginning, I'm going to put down something fake, this is not you, like whatever it was, even though he tried to say that, it didn't work out that way. So I think that there's some of this that's going to be about how people use it, and Claire knew to do that, but I don't know that all trans patients are able to do that.
I think that's right.
In order to gain power from using the system, you have to have access to power in other ways. So you have to have access to education and community knowledge and a certain amount of literacy to know the right words to use.
Exactly. And also I think there's going to be an emotional reaction. That's the other piece, that even if you have that, I think it's also key to remember that even if you know going in somebody's going to say you have gender dysphoria, it may still be incredibly painful to be told that you have gender dysphoria, and to have to be marked that way to get the access. Like that also has some emotional reactions, right?
Yeah. So building on that, on page 177.
Thank you.
When he says, my slow turn from butch dyke to genderqueer living as a man in the world was never about curing disorder or fixing brokenness, but rather about desire and comfort. Transition, a door, a window, a cobalt sky. So that really struck me as a beautiful articulation of sometimes when we're looking for treatment or cure, the doctor, what your goal is that you want addressed might not be the same thing that the doctor thinks.
Yeah, and where the desire gets placed.
And and if you say I need some treatment to fill my desire and make me you're just gonna they'll feel like it's not medically necessary. So you have to present something in those terms. And I think that looking at this from the disability studies lens, this is a good example of how disability experience is generative. Yeah. Linking to what you said about community knowledge. So he had a kind of rehearsal through dealing with disability his whole life to know how to
move in and out of
move
those.
in and out.
Yeah.
So there's a
That's right.
relationship.
He had the access already to the disability community. And that is a certain, right, location that enables you to know what language to use, and, yeah.
And in terms of getting specifically gender dysphoria diagnoses, people, especially for non-binary trans folks who are not going in with the narrative that doctors traditionally want to hear, we have created a very extensive wealth of knowledge of how to have those conversations and how to lie in those conversations to get what you need. But in order to access that, you either need to have access to a trans community, which usually happens in larger cities, or you need access to the internet, and you need to have access to the knowledge that it might be out there and to find those things that people have already written.
Or even just access to a recognition that there are non-binary options.
Yes.
And I think that this is, I mean, culturally, I think this is changing, and there is a kind of larger cultural awareness, but part of that kind of the way that the ideology of even gender binaries work is you have to imagine something that's possible before you could even go looking for the community. I think this is part of what that centering on, whether it's kind of ideologies, the ideology of care forces us to see and think about what we can imagine is possible. And that's independent of even a doctor who may not believe or who may know diagnosis is flexible. Or, you know, an individual person that's like, okay, I'm gonna accept this diagnosis is flexible. It still carries this kind of collective cultural weight that functions in really particular ways.
I'd like to suggest that this is going to be a point we could really spend with Eliza's story with microdosing. So maybe we table this for now and then move to that when that comes up.
Yeah. So we have a couple more minutes left on this before we move into it. So I just want to make sure how we've talked a little bit about this, but really focusing on how his toggling between concepts problematizes not just the binaries between health and illness, but gender binaries. And what does that open up for us as readers?
One thing I'll say is to bring to the fore why the language of medical and health really need to be considered very thoughtfully. Because if you're looking at ICD-9 codes and, you know, your diagnostic criteria, it's not about health.
Right.
But disease.
Right.
And I think that a lot of what we're talking about is what this person needs to be healthy in the fullest sense of the word.
Right.
And the way our best industrial medical complex is created, we don't allow for that.
That's a really good insight, I think, because I think it also, it's really broad if you think about all of the spaces in which we should be thinking in terms of prevention and, you know, whole body wellness kind of stuff, like, I don't like wellness, but you know what I mean, like taking care of the person, right? And it's broader than fixing something. It's bringing somebody to cobalt sky, which is the most beautiful phrase, I think.
Yeah, it's the human flourishing.
It's the human flourishing, exactly. And that's not an insurance code.
And to think about, you know, that we're doing disease care, but then that the diagnosis of disease may be perpetuating the idea of not preventing and encouraging wellness. You know, that just the terminology around it and the need to pocket somebody in there has its own energetic sense of disease promotion, in the sense like, I am this now, and I'm, you know, and how strong our will to be a way or another way, and when you're given that framework, how powerful that can be to lead you down that path.
Yeah.
Even psychologically.
And cure has such a punctuation mark to it, like a big period, right, at the end of it, whereas health is this constant.
Yeah.
Right, you're
I love
constantly
that.
striving
Oh my
towards
God.
health,
Yeah.
right?
That's a good point.
That's a really good point.
Can I here shoot
There
in?
is no cure. Please, anything.
Go ahead.
Oh, sorry. I was just gonna jump off of the reference to cobalt blue sky, because I feel that Claire uses, so Claire mentions metaphor, like reflectively talking about the way he tried to transmute I think it was Claire, or am I thinking of the Enriquez, the the testosterone, was it? Something was transmuted into the honey, light, and like sugar maple. And so then he says he uses metaphor. I forget exactly. Oh yeah, trying to wrench my transformation away from the medical industrial complex through metaphor. So language itself then becomes a way of escaping these binaries. And I feel like that's in itself a really important tool that needs to be put along diagnosis, is the way people use language, because it often is seen as trivial in comparison to like objective science, right? So it's a way of circling back to language.
So speaking of that, I think it really relates to the period point of like I think he talks about transitions so beautifully in this section. I mean, I continue to think that my slow turn sentence is one of the most perfect sentences in this whole like piece. But I think he describes the sort of, that's on page 177, the one you quoted, my slow turn from butch dyke to genderqueer living as a man, white man. But also I think that whole section he's talking about a transition, and he goes back and forth about like what this transition looks like, and then he goes into this thing about taking testosterone and hungering for a settledness, and things like that, that I think it's all like working with this concept of the gender binary and talking about whether he wanted it or not. It's very interesting. I think he's talking about the lack of linearity, I think.
That movement piece. And I think one of the pieces about focusing on the language or the metaphor is that it also prevents us from picking up health or wellness as its own form, having its own place in the medical industrial complex, right? So I think in some ways health and even wellness or well-being has been taken as the corrective to medicine, and in some ways can easily get wrapped up in that when we create binaries. Like health is better than diagnostic and disease. And I think that what Claire is doing by forcing us to think metaphorically is, I don't know that we have space in what we imagine wellness to talk about honey. Outside of the curative properties that honey has.
Then we'll get in trouble because they'll say we're drug seeking. They'll be like, oh, that opioid medicine makes you feel good. Sorry, take it back.
But I think that
I've never done that.
No. This is a good time to meet.
I think it's a great point, Allie, and that is, I hate the empathy stuff, but I also hate the resilience stuff that's come out, because it's turning into this oppressive thing, like, are you resilient, are you not resilient? And that's the way that wellness has ended up getting discussed now and operationalized, and it's just reenacting the same, right?
Go ahead. Well, I think the resilience thing, especially in medical education and such, is we're not changing the structure.
Right.
We're going to give you tools so you can be healthy within these oppressive structures.
Right.
Well, the good news is that, this is an aside, the good news is that's shifting a little bit. The medical students are fighting that, residents are fighting that. There is a groundswell of people noticing that this resilience thing is not enough, that the structures need to be shifted. So I think that is
in practice.
Let's change.
I'm sorry, 1 second. In medicine, though, it's not yet. It's maybe medical education, but no, not in medical practice. I'm telling you.
I believe you.
If you haven't read Jay Dolmage's Academic Ableism, he's absolutely brilliant on this topic he talks about the wellness movement being offloaded onto students, that they're basically being burdened with their own burnout and care. Awesome.
Okay, so let's move.
So we don't cut into too much of the other time. We could talk about Eli Claire forever. Sorry.
I'll just do a quick wrap up before we move on. But part of why we wanted to start with Claire's text is because it brings together his experiences as a trans disabled man to trouble this kind of imagined trajectory of cure, both from disabled to non-disabled, but also and from sick to well, but also the cure from being or having gender dysphoria into cured trans man as a singular narrative trajectory. This critique provides us with a lens through which we can trouble assumptions about that imagined narrative trajectory. So to do so, I will again hand it off to my colleague to talk through the second piece that you read, the power and limits of classification. And again, I will step away from the podium.
Come sit with us. So we'd love to talk a little bit about this New England Journal of Medicine piece. So this is a piece that is a part of the social medicine series. And so you'll see it has some analytic stuff connected to it. What we really wanted to do was talk a little bit about the story that you read here, the case that you read, and also sort of have you think a little bit beyond the analysis that was given here, and to think about how having the frame of the cure makes you think differently about the story that you read. So first, I just wanted to hear your thoughts about how the article and Sam's story in particular challenged your notion of trans health, of the things that we were talking about before, if at all, like the kinds of like reasons trans health disparities exist, and how the article raises questions about the binaries that we just talked about. And I'd just love to hear about that sort of to start. What are your thoughts after reading this?
I thought it was brilliant to pair this with the other article, or with Claire's work.
Thank you.
Because they really speak to one another, and this article pulls out especially the assumption that if one is trans, one wants to be the opposite gender and sex and sexuality, that it's a binary, and that the person going through the process of discovering identity or what they want to be, it shifts and changes as he encounters people that imagine different possibilities for him. He could see himself for them. So we should have, maybe an idea, I was thinking, we should have which pronouns to use for which authors, because it's
he, them, just so you know, for these three pieces. Sam uses he.
Okay, Sam uses he. All right, thank you.
Yeah.
He, them.
He, them. Eliza uses them, so it's.
Eliza is the microdose.
Microdosing is them, so Eli Claire uses he, Sam uses he, and Eliza uses them, which is microdosing. But we can also write that up.
Put that in the teaching.
That's useful.
Yeah.
Helpful. I agree, that's helpful. Yeah, we should. It's hard, yeah, you want to use, yeah.
It would just make it nice to have
Yeah, that's a great
the
point.
pronouns available without having to
Yeah, that's a great idea.
feel like, I'm going to say the wrong pronoun. And
Totally.
then I will just be reinforcing the gender binary.
I know, it sucks.
And a super quick note, we should also do that for all of the portraits.
Yeah, it's a great point.
Yeah.
That's right. It's a really good point.
Michael, take notes.
I'm all set.
Great.
You're totally right
And
about
so
that.
then when he started taking the hormones, this very small dose.
Oh, no, we're not there yet. Sorry.
That's a microdose.
No, sorry, that's why it got confusing. So we're talking about the abdominal pain. I should have made that clear.
Yeah.
Sorry, I
I said
should.
microdosing.
Sorry.
I'm
You're right.
gonna take us through microdosing.
It's the JAMA one.
Yes.
Okay, well, forget everything I said.
Well, it's also brilliant to have used this one too. Thank you for all
No, it is very.
So
They
this
all work
one, right,
so well together.
okay, that also explains your comment better. Okay, so this,
Okay.
let me do a quick summary, just to make it clear which one we're talking about. This piece is a piece about Sam, who came to the ER. He's a trans man, he was in abdominal pain, and the nurse who brought him in didn't notice that he was in labor, and he had a stillborn child. And there's some analysis about the limits of classification. That's how the analysis works. And there's also a short sort of follow-up at the end that talks about how Sam no longer uses testosterone and now wants to menstruate because of his concerns about being pregnant. That's the sort of summary.
And even then, it's not like, he's not using testosterone because, he wants to have a baby and so he can track menstruation. So that kind of, was something I took note of too, because then there was assumption, even as I was reading the sentence, that got flipped by the end of the sentence.
Right.
How that sentence was gonna end.
Mhm.
Yeah.
So that, this article does a really nice job of doing that for the reader too.
Well, and then that kind of gets into how you begin to have a certain expectation for how the story is going to go, right? Based on all kinds of these preconceived pressures and such, right? Or preconceived pressures, but the pressures of the narrative.
This gets back also to the trajectory idea that Eli is, sort of critiquing, right? That the nurse just starts going down this road.
Yeah.
And, to this inevitable end. And she doesn't consider all the other permutations.
Right.
She doesn't do a physical exam, right?
I don't remember.
It does not,
It sounds like
she assessed
the
him.
person who came got.
Well, the nurse ordered some tests.
Yeah. Go ahead.
I thought that it reinforced the impact of having to put on medical records what your name by birth. Because a lot of times I think about it by like respecting the way people want to be referred, but in this instance, like seeing that all of the other chains of effects that can have in terms of like, if you read that, all these assumptions that can be made that would impact the kind of medical care that you get. And so I think, the students did something recently, developed a medical curricula on this, and one of them is transgender, and it made me think a lot about the advocacy, the need to change a lot of the medical forms and the thing that needs to be more inclusive. And, I think it's really important for medical students to think about all the different consequences of even just that one thing, that it's not, that it runs much bigger than just to be accepting and respectful. There's so many other things that can come with that. And I don't think that in the medical encounter, they often think about all those other consequences. So I think this is that really reinforced it in ways that the other pieces didn't.
Right, because I do think that's part of what's interesting here is that from a trans health perspective, in some ways, she gave very respectful care, right? She used the correct pronouns, she cared for Sam in respectful ways. But what she missed was, because she made assumptions of the cure, of the fact that he had fully transitioned, however she felt that meant, right? She assumed that meant that he was not going to be carrying a baby, basically. That she made that quick assumption. And I think that's where some of these things come from. I think that you don't
actually misspeaking because, because it was.
Right.
Well, it's still relevant.
It's still relevant what you
the name that you have to put, so the name was actually a female name that needed to go on.
Well, it doesn't need to be about the name, right? What's necessary isn't necessarily a name, but is.
I'm just saying that's legally required, right? That you have to, don't you have to put the name you were assigned at birth on medical records?
No.
I'm my argument.
No, but
that was the point.
But what
I still had to do that.
Down record, how it's built, because each health system will build its own, and sometimes within a health system, there's several different types, so.
Right.
And I think there are a lot of health systems that kind of grapple with how do you, make sure that if, on the one hand, are being respectful.
Right.
On the other hand, are not sending somebody down a trajectory that could miss important medical, possibilities of, this is what happened in this case.
Exactly.
Yeah, and on page 1888, because the author of the article says charting sex at birth, gender identity, and legal sex as 3 separate categories on formal documentation can enable nuance and appropriate care.
Yeah.
And then goes on to describe that a little bit.
Yeah.
So I wanted to add another.
Didn't know I said it wrong.
No, we get it.
Well, and also there was another assumption made, was the patient's weight.
Yes.
So there's a little bit of, there were some assumptions about someone who was, I think the author used the term obese.
Obese, yeah.
But someone who was larger, that
He was an obese man who appeared comfortable between bouts of pain, right?
Right, and I think I've heard this from, fat women, I'm just gonna use more activist terms.
Yep.
Is that, the pregnancies would be missed because they're expecting certain bodies to be pregnant. So there's that kind of intersected in that situation as well.
Mm-hmm.
And to be desired, right? I mean, part of it too, right?
Right.
That a fat woman is not going to be
having,
desired, right?
Yeah, with his partner, because he came in with his husband, or his boyfriend.
Yeah.
Came in with his boyfriend.
Mm-hmm. You were going to say something else?
No, I want to go back a tiny bit just to further complicate issues of names and gender and sex markers. So generally, in order to bill insurance, you need the legal name that is currently on the insurance card, which may or may not have been the given name, so people can legally change their names. And then once you legally change it, as long as it's changed on the insurance, also, you never have to mention the original name. However, if you change your name while under the care of the same medical system, that old name is generally still linked to the file.
Yeah.
And they essentially refuse to get rid of it, or at least in my experience, that is what happened here. And then you can also change your name however many times you want, and you can change different parts of your name.
What about sex assigned at birth? Is that required to be reported in that way?
Well, no, because most places still only say sex, which could mean a million different things. And in some states, you can now change your birth certificate to change the sex that's on the birth certificate, so that can be different than what the original sex marker was. And then you can also potentially change the sex marker only in certain places. So there can be people who their legal identification, like a driver's license, has a different sex marker than their health insurance card. And because there are now non-binary options for some driver's licenses in some states, you can also have a third option between like a driver's license, a health insurance card, and a birth certificate. So there are, I think that starting with the three questions of what was your sex assigned at birth, what is your gender identity, and what is the current sex marker, only get at the beginning of the possibilities, because you can have so many variations, and none of those actually get at the question that you need of what organs do you have,
What's your body?
and also like what is your hormonal makeup at the moment, which also for cis people can be very different and is not necessarily represented by any of those markers.
So, and that's really key here, because I think the first part of what you were talking about is really about classification, is really the key of how they're analyzing this case. And I think that piece is fascinating in and of itself, and is really important, is thinking about how we don't really have good classification systems right now, our EMRs don't work, et cetera. But then there's this further issue of how we think about bodies in general, and I think this is where disability studies frameworks really helps us to look at this case even further, to think what was going on with Sam's body and how were we thinking about Sam's body and what was going on with his body. We were thinking about, the nurse was thinking about his body as having this particular problem, but also having been cured, right, of this gender dysphoria or whatever she was imagining. And I think that is the piece that is fascinating to me, particularly around this case.
Can I
Yes, please.
chime in? Sorry, I feel like I'm barging in every time.
Should never feel like that.
Okay, I just don't know how to raise my hand. I guess for me, I wanted to raise the question, or just pause to reflect about how this works generically related to the other essays, because so the core group knows my original kind of crankiness about this article, and I think it's partly generic, the way the article's written, which is it's a New England Journal of Medicine article, and it has that kind of stripped down structure that's familiar to us with bioethics cases and clinical cases, where there's kind of a straightforward solution to a problem. Like oh, I didn't go down that right pathway, but if I had, I would have gotten to the right screen, or the algorithm would have worked if I had just known that my classifications needed to be different. Whereas I feel like the other articles are actually merging theory and narrative in a way that's less linear and less neat and instrumentalized in important ways that I feel like I'm being incredibly articulate about. But I'm kind of interested in a way, and I'm sorry I'm being super meta now, but the way that the Charman appendix from the Remedy is sort of like a reflective narrative moment, and then saying we also need statistics here, so here they are. So it's almost like a kind of like a leveraging of cure or of diagnosis, a leveraging of statistics. Is there a way in which in this entire teaching guide, there's a leveraging of this genre of case?
So Rebecca, can we save that conversation for the meta part after we finish the case or the portrait, and then
for the revision,
to the revision section?
I thought about that, but I'm just going to say it's so hard to hear, and there's a lot of ambient sound and stuff that I'm not sure I'm going to make it through to that section. So I just plop that out there, and I'll try to hold back on that stuff now, but I'm just not sure I'm going to make it through that second half.
Got it. I appreciate it. Well, okay. No. Thank you for that input. I'm just trying to stay aware of time.
But I mean, I think it leads us into, sorry, I'm taking over here.
Please, take your conductor.
It leads us into this larger discussion of what's missing from this clear and simple solution to a much messier problem. And I think this is what pairing this case study written in the way that it's written the commentary offered the way it is, why we kept it in, is to ask that larger question of what's missing.
And also, I would say that it helps us understand the consequences of thinking in a binary way. And that, for medical students, I think is really important. So, you can say, oh, just don't think in binary ways. But this is like a real consequences to what happens when that thinking, gets played out. It's an example of one. Yeah.
I was going to say, I think it's JAMA. They would have written this up, I think, a bit differently. And they would have had Sam's voice.
Yeah.
So rather than having, the health professionals writing it, there's a format where you have the different stakeholders describing the experience from their perspective, and it almost becomes more dialogic, where, to me, that's a much more effective strategy for telling a story like this, because Sam's voice is only interpreted.
So this is part of our critique that we write about in our article. We take on this social medicine case thing, and that's one of the critiques that we came to.
And then also, I think one of the other reasons we liked this piece is that it does demonstrate or illustrate for us well-intentioned healthcare providers acting on what they think is in the best interest of the patient. It's really well-intentioned.
And it's actually quite progressive in many ways for, the medical literature, but it still falls short.
And I think one of the things that's really interesting about this particular story, which I think it's a really important critique that it's not written actually from Sam's perspective. But to me, I think part of the reason I highlighted the epilogue or the sort of case follow-up is that I think it particularly sort of is fascinating when you think about the cure perspective, because in some ways, Sam had experienced a bit more was living a more binary life before he experienced this, and then had a less cured version of gender dysphoria, if you're going to think of it that way, after this experience. And so it's sort of like an interesting trajectory if you think about his lived experience, right? And and so I think in particular it's again, it shows a lack of linearity in somebody's lived experience. It shows a major mistake of both classification and of this like thinking in such binaries.
I do wish, in addition to wishing that I heard more of Sam's voice, I wish I heard more of the nurses' voice there. You know, in a way, I really feel for the nurse there who's very well was like, gosh, you know, I've had patients who are trans men in the past, and I've told them that we have to do a pregnancy test before a procedure, and they're highly offended. I feel really uncomfortable about that. So we stopped doing that,
right.
you know, and now, you know, now here we are. You know?
Right.
So I think I feel for the healthcare professionals who are just grappling with trying to figure out what is, you know, what really is the best, most prudent thing to do in this situation.
Totally. Yeah.
I think there's also a lack of recognition of the whole of his story, because he did not come in because he all of a sudden had pain. He came in, or this happened because, first of all, he lost health insurance coverage.
Mm-hmm.
Why did he lose health insurance coverage? Does that have something to do with being trans? Does it? Yeah, it has everything to do with our system of healthcare being tied to employment. So what is that story? Also, what is the story behind whoever initially prescribed him testosterone and may or may not have informed him of, if you go off of this, you can become pregnant if you are having the type of sex that could lead to pregnancy? And was he fully informed of that? Did he get that information and forget it, didn't think about it? There were other things going on in his life. There are just so many things that came before this that also touch on medicine that I think should be addressed.
Other textual care issue, right?
Totally.
Yeah.
But I mean, this is precisely that, sort of situating and understanding experiences of medicalization aren't just about the individual body-mind in that moment, right? And this is what, even though we're not using any language of disability in all of the structural things that you were saying, the lens that forces us to see how bodies and minds interact with systems and structures, and that trains us to do so, allows us or helps us get there. It's one avenue to get there to those sets of questions.
I think it's interesting that in the article, when the triage nurse is working with him, he had even taken a pregnancy test and told them that it was positive.
Yeah.
But then also it was the high blood pressure was factored in there, and losing insurance and not taking that medication.
Well, so I think what's really key here is that it's being filtered through a lens, right? So I think that's what's really interesting here. It could be a lens of classification, but it could also be this lens of seeing somebody as pattern recognition, as a pattern recognition of, I see somebody, they're a trans man, so they're a full trans man. They're whatever that is to somebody. They have gone into
even if they have positive
a positive pregnancy test, right?
Yeah.
Even if, like,
we're going to say, it's a false positive.
in my
because
head,
they're cured.
right? And that, I think, to me, is what's so striking about this particular story, is that it's not just classification, it's what we're using classification to do. That, I think, is what's really key. And the fact that we don't have multiple forms of understandings of groups, in part because we've created this secure dynamic.
I think that is also a good time to transition. I know each of these pieces we could spend a lot more time talking about them, but actually the microdosing text is the heart of, it is the first person narrative of this portrait. So the rest of what we have been talking about, even though the Claire piece is both first person and scholarly text that we've offered you, but this is the meat that we want to get into. So we'll hand it off to Michael.
Yeah, so these are, as Ali said, we've kind of saved the best for last in some ways, right? The first person account. After having gone through a rumination, a kind of thinking about through theory about identity with the Claire, right? And then into the use of this narrative, this cure narrative, or this endpoint in the Sam story to this, right? Where this is an individual who discovers that there is such a thing as non-binary identity, right, through community and such. So these are kind of like how our guiding posts as we go through here. How do these passages, we're going to put some passages up because we're going to spend time with the text and respect the first-person account here, right, and really draw your attention to specific textual passages.
The page numbers?
Yep.
With page numbers?
How do these passages reflect the concepts of cure and medicalization outlined in the portrait so far? And then what questions do we ask of these passages when we read them through a disability studies lens that is, critical of diagnosis and cure? So we push the next one, please. So this is the first one we want us to think about. And then we kind of got to this a few times, right? Like working with, even with your Rosenberg comments, right? Or, right, is working with, there's something about getting, working within the system to get a diagnosis, yeah, right? So what do we do with this?
Also, I would like to point out, Shay used this language too earlier, the lie.
Yeah.
Oh, yeah, the lie. I mean,
The lie.
that's pretty common, actually.
Yeah, it is.
Not just for trans care. I think that's right, Carrie? I mean, okay, don't say that in front of your doctor.
No, I If you have a good doctor, you don't need to lie.
Ah, nice.
Nice.
That's why we're
Are you telling, I'm lying right now.
Yeah, I mean.
We're lying together.
I feel like there's something that happens the minute you walk into the door of a clinic where you lose your language. And you from the minute you're, standing in front of a signature panel with no text attached, and someone's just asking you for the numbers associated with your identity, you become obedient to the prompts. And, no matter how normative you are, you get subsumed into the logic of those prompts. And it's happening to clinicians too. I loved, Christy, I think it was you mentioning the diagnostic codes that are driving the language and the structure of the language. But this is like another level of heartbreaking, where it's so difficult to have an identity that you can put forward in order to make your embodiment match. It's just, it's really powerful.
And there was a connected lie, because there was a lie to the family as well.
Yeah,
so that
that
brings in, it's not just
lie.
happening, the need to fit into a binary in the clinic, but it's everywhere this person's turning. It's like there's expected narrative, but then it seems like the truth is kind of difficult to even pin down, especially when there's so few guideposts that can make sense. Because they seem to change in this narrative more than once.
Well, I think the only landmarks at this point for ELISA, right, are ones built around cure and binaries, right? And so those are the only landmarks that they have for navigating this terrain. And then, so then it's when they begin to understand other landmarks are out there, right, that the narrative shifts.
There is no cure, right?
There's no cure for anything.
So I think that's also part of what needs to be unpacked, actually, with all of this, because cure is a falsehood.
Yeah. It's a myth of medicine.
You just lost the patient.
I think, part of what makes this also very challenging when you look at sort of the performative aspects from both sides is, there is a script, and you know what you're going to have to write to be able to get the insurance approval. And so what's the goal of medicine?
Right.
What is the goal of medicine that's being served? Because it's not really cure. And it's going to go in the individual's definition of what human flourishing means for them. So when you look at the WHO language and you think about health, we get into language of human flourishing, but that's not recognized.
No, it's not.
By our healthcare system as a legitimate goal of medicine. So I think that the language, again, is something that we've got to go back and grapple with, because the medical student's going to be really worried about that. You know, I'm going to be a doctor. What am I supposed to do, you know, when I have to frame it in terms of a legitimate goal of medicine?
So what I was going to say when Michael was talking was, it's just reminding me of sort of the good patient, right? And the good patient not only in the clinic, but the sort of good patient outside the clinic with the lying, right? It's this, all these expectations. And then there's the expectation of being the good doctor.
But think about the lie. So how does the act of having to lie also affect your sense of health and wholeness?
Right.
You know, I think that that's a real issue here in terms of knowing that if you were just your authentic self and being honest, that somehow you're diminished or you're not viewed as worth it, or, you know, the goal of whatever it is that you're seeking is not valued.
Well, where does the lie come from? Where does the need to lie come from? And I think Michael's point, I think, is really important with this, the living the lie concept, because, you know, I think it's really important to point out that they were lying when they came out to their mom, right? Like, Eliza had this, but they were lying because they didn't know different, right? They didn't have language or an understanding that there was something else. And so once there is a knowledge in, you know, society or what else, there's that reason to lie, is that you're living a lie because it's not who you are, but you don't have any understanding of what you really are, right? Like, and that happens for folks. But then there's the other piece where you have to live a lie because there's some other structural thing forcing you to live the lie. And I think those are two different painful experiences that Eliza had to live through both.
Yeah.
And I think that's really key. But I think that's a different level of emotional.
But there's an adjustment and an identity issue.
Yeah.
That is harmed, hampered by having to live that life, particularly while you're coming to that solid sense of identity.
Right.
You know, this is who I am, because that strength you need to be able to go into an office and confidently explain these things is not something that happens overnight. And I don't know, I think that there's some dancing around here, you know, so I think we have to talk about the structural elements, because a lot of what needs to happen is not going to just be in that doctor-patient relationship.
Well, and I think also that even language here, the solid sense of identity, assumes an endpoint there, right? When we go back to Claire, the open cobalt skies, endlessness, which means constant. And even Eliza says glacial speed in terms of reaching this goal.
Yeah.
Right? And so it's not so I think we have to be careful that a solid sense of identity how different is that from being cured? Right? Arising at the end of the narrative.
Right.
Right. I think that's key.
And I would just add also, I think that the structural piece, at least as we intended it in this portrait, we could talk about that in the second half, that is exactly what we're doing by talking about the ideology of a cure. That's part of it. That is the structural component of this in terms of like systems of thinking. It's one piece of that. But we could talk about that in the piece. But I think it's part of what you're saying in terms of like the structure that shapes posits lie, the truth as in opposition to the lie, and it creates another kind of form of binary that is part of the discursive language that we have. To say your true self, your authentic self, we imagine that to be a singular self. But Eliza's giving us something different, not a fixed self. That truth is a little bit more flexible.
And so Eliza's also challenging the sort of moral complicity of a health professional in executing decisions that may be irreversible. So, you know, having to, if you want to have the breast surgery or, you know, whatever, there's that sense that, well, we want to know that the person is really making a fully informed decision and won't have regrets later.
Forever.
right?
Like, it's gonna be a forever decision, right? And that's also a big part of.
So there may not be, you know, an authentic self or a place where you're done in terms of your evolution, but you want to know that before you intervene to do something irreversible, that there is, so how, you know, do you navigate that?
But what is reversible and what is irreversible is also a flexible category, so people have breasts put in all the time.
Yeah.
But, and then there we get to this kind of ideology of, well, what is original or natural, and that, right, so all of that gets weighed, because people have breasts removed or added on a relatively regular basis, right?
And insurance, so again, a lot of
then
this
this is
is
another, yeah.
So
I can't imagine coming back after you've done the breast.
But I think what I'd like to do is to stick with the text here, and because this would be stuff that we could been thinking about, okay, when we're teaching this to actual medical students, right, how we could be using these concerns, and that is there, okay? So let's stay with the text, and so this next one here,
All right.
looking at images of trans men was both comforting and not, a haze of uncertainty. I spent my therapy session describing this haze while maintaining a cool exterior to show that I wasn't upset by questions that locked me into male and female.
Can I just say that the haze here is in conversation with a cobalt sky?
Yeah, absolutely.
And I feel like, you know, just to actually riff off what the conversation that was just happening about Claire, I feel like this is such an important passage, and I love that you're doing this, by the way. And I don't know if you've written this into your teaching guide, but having these passages either on a screen or printed on a page, and
they're on the screen right now.
Really getting people to teach this by focusing on these specific passages is just brilliant. But the relevant commentary from Claire for me is related to ideology of cure, is that there's nothing inevitable, natural, or inherent about GID or GD. They're fabricated categories that reflect current white, Western, etc., cultural and scientific values and practices. And I feel like this text so well illustrates that and upends this idea. And I guess even this text illustrates what was going on in Claire when Claire's talking about basically internalized ableism within the trans community when gender dysphoria is articulated as a birth defect.
Yeah.
You know, that this Enriquez text really just opens that out in a way that is so, I feel, will be so accessible to students and to learners of all kinds, because it's very, even the haze seems clear in a way.
Well, seeing clarity in the haze, right, in some ways. So in terms of this, any comments on this passage, given what we've brought to the table, the lens we've constructed?
I mean, this is kind of the lie, right? That there's a haze inside, but on the outside, there's a cool exterior that's thick.
With binary.
Yeah.
Yeah. And it relates to an earlier, or another part in the text where we're talking about enjoying and confusing classmates and loved, what was it? Like, messing with people basically on names and everything. So it's like also the emotions around it are shifting. So there's these relationships to these categories that's just not all about trauma feelings, but also there's kind of there's haze, but there's also manipulation or playing tricks on people, that kind of
pleasure, feeling good about having that. I think it was using the middle name Michael. And, and the pleasure of just that was that person's own way of claiming identity in a very subtle way.
And also empowering. I mean, is that what you just said?
Yeah.
No, it's regaining the power, it's taking it back.
Yeah.
Yeah, thank you. Here's like my little fan.
Did you want to ask a question?
So,
So many things.
I like that, yeah.
Attempting to respond to what was just said. I do think that type of regaining power is also an example of where labels could have been helpful to complicate our conversation about the problems of classification.
Yeah.
Particularly within queer and trans communities, there's a lot of conversation around, like, should we get rid of all labels? But also there's a lot of power gained from having a label that identifies an experience, and particularly a shared experience, so you're not alone in what you're experiencing. And I think that knowing that you are getting joy from confusing people is still seeking additional understanding of what's going on.
Well, and I think that, at least in my understanding, again, I'm still relatively new to the disability studies framework, but I would think there's actually very similar things coming out of disability studies around the importance of naming, and that's really what we were reading in the Claire too, right? Of the, like, both positives and negatives of having a diagnosis, and diagnosis is nothing if not label, right? Like, is nothing if not saying, here's what's going on. Because I think there's benefits to be able to say, I'm a part of this community who all has epilepsy. Right. But there's also a downside of saying you have epilepsy because you aren't that kind of epileptic. I mean, that's my lived experience, right? And so, like, I think there's it's this really sort of, both things are true, I think, and that's also true for this.
So, yeah, when you said that, the first thing that came to mind to me is this quotidian resistance, right? It's like the one space that you can resist this stuff, right? I mean, I do it all the time, and I think people with disabilities do it all the time because you're so powerless. You find this one space, I mean, I think it's great, to resist. And through that resistance, like, part of your simpatico with other disabled people is knowing that resistance and feeling it, right?
Like getting into the building today, the curb cut was too steep, so I got out of my chair to push the chair at the curb cut. I got the most wicked look, like.
You're not supposed to be able to do that.
The order of things is really fucked up right now, right?
Yeah, so I mean, that's kind of a.
I mean, it's funny about it all the time. And we joke about it. It becomes a joke, right? And so, but it's really it's a strategy. It's a strategy.
And it's a strategy out of, like, learning to live with all of those horrible stereotypes. That's not always playful.
No, like,
we can
it can be violent too.
Right.
Sometimes
Yeah,
people
that's
respond
true.
with violence, so you have to, and to
You
bring
have
it back
to know
to
when to do it.
and to bring it back to the passage. This is connecting what Shay said, because right after this question that's asked by the therapist, they answer, I just wish there were other words for that.
Yeah.
So it's another kind of looking for a
And there
name for a role.
and I think that that's what's been really interesting to see in the non-binary trans community in particular is, like, shared language for husband or spouse. There's been a lot of language of parents. Yeah, there's a lot of terms that people have started to sort of incorporate that I think also highlight the fact that, like, you're a part of this shared community who. The thing that is the problem with that kind of classification is then people make assumptions as soon as if you're using that term, that means this about your identity, and that's a problem. But if one of the things you're trying to do is create, like, coalescence within a community, I think it's a really powerful thing, like Jay was saying.
And the quotation that you drew our attention to, wishing there were other words for that role, is what they says to the doctor, but that's the beginning of, okay, there's other ways to talk about this and to imagine identity, right? It is grounded in language, though, right? And it's very much saying that language is so important here still, right? And the naming, but looking for the new names, I guess.
Right.
So we'll do the last one, and then we'll do our wrap up, and then we'll go meta, okay?
Feel good? All right.
So for non-binary people, and we're filling up what that meant, the complete medical transition can serve as reinforcement of popular narratives about transness. And otherwise, cis contexts are premised on how far along an individual is in their complete medical transition. Microdosing rejects that notion because it is a process that is without a hard and fast end. Any comments?
Yeah, all these quotes are just really bringing home the clarifying, reinforcing the main points that you really want to pull out. And, they're beautifully stated and well written, and I think it helps. Yes, meta, isn't it? That it's, anyway, that's more of a, but because I feel like that's why my comment is like, there's not a whole lot more to comment, because I feel like we've all.
The lines said it so great,
There's a lot has been said, and then it just kind of drives it home, so I think it wraps it up in a nice way.
I thought this was so amazing and noted it in my reading because it drives home health humanities really, or like it justifies health humanities because it points out that narratives drive, or narrative itself drive appropriate, what's considered to be appropriate medical care. That it really does, kind of recognize that the way that these discourses are informing what happens in the clinic.
Yeah, and then were we to read the starting on page 7, microdosing testosterone can completely change non-binary life?
Yeah, you could, I mean, that wasn't a part of what we were imagining, but yeah.
Well, to drive this home even further with this part of the text is then that Eliza stopped taking testosterone. So even after the story ends, there's another part that changes the landscape yet again.
Right.
I just want to say, I feel like there's a article here that has microdosing and metaphors, and that they're forms of counter narrative, and they're actually anti-narrative in a way. And yet, I mean, these are like incredibly powerful narratives, right? They really are counter narratives. They're really important ways in which they're resisting these quote popular narratives. And it's true in the New England Journal of Medicine, article as well, that misdiagnosis had to do with a narrative, an image of what the story was that was really driving the whole prescription process or diagnosis process. And it's really about resisting the power of those stories and breaking them up. And microdosing is just this beautiful, literally medical counter narrative. It's really cool.
Yeah.
And I like too how this ends, right, and this is back to Shay's point about community or individuals you can talk with and that such, right, because it ends with naming these individuals that they turn to, right, to understand this non-binary existence, right, living in this non-binary, and it ends with, I use testosterone to access this freedom, slowly inching my way to a soft, forgiving space. So it's very interesting how it's actually a physical space, but also, I think, psychic space, right? Where I could be gentle, hard, bold, and understated, right? So these kind of juxtapositions as well.
Yeah.
And then myself.
Amazing.
Yeah.
Yeah, that's fabulous.
Yeah.
Because we think of and in this case, it is a cold space. And what Eliza's trying to get at is the soft space, the vulnerability, and embrace it.
She has something to add.
Oh, sorry.
No, fine, trying to connect a lot of things that I've been wanting to respond to. I think there is an additional narrative that needs to be highlighted, both in terms of trans healthcare and also what the experience of trying to access healthcare for anyone, is that there is a significant story that happens before that is accessed. And I think especially with the framing that you brought up earlier of like, well, how do I know that it's okay to prescribe something that causes this irreversible change? There is also irreversible change happening in waiting and denying care.
Right.
And especially for trans folks, you're generally not seeking care if you're okay. Like there's something going wrong with your experience of everyday life, and the harm that that is causing is also irreversible change. And that narrative, that experience needs to be taken into account when we're thinking about how medicine is impacting people's lives.
Well, I'd love to, you seem to be saying that the story doesn't begin with medicine, but we often think it does.
Right.
Right, that's not the beginning of the story.
Right.
That's part of the story.
And the other thing you're saying is the impact of the non-doing.
Right. Well,
And what, everything that comes before becoming vulnerable enough to go into a space with the doctor to figure this out. I think those are really important.
And that echoes very much the sort of diagnosis piece of when you're thinking about what's going on. Physicians are trained to fix things, right? And it's like an intervention, and they have to make a decision, is this intervention appropriate for this thing that I'm seeing, right? But like, what I hear is that it's also about the problem that, like, stasis is the problem, right? Like, that staying in this, right? And I think that's an interesting way.
Yeah.
I'm repeating something you said way more.
I think it's actually brilliant what you just said, because we always talk about, and Rosenberg talks about this too, is it's the diagnostic moment. And the diagnostic moment is the beginning of everything. But it's on medicine standards. That's medical language, that the diagnostic moment is the starting point. But actually, in people's lives, the diagnostic moment is part of a continuum. Yeah. And, you know, and like, sorry, can you go back? Yes, that the cure or even the managed treatment is, in medical epistemology, the sort of end. But it's not the end for the patient, ever. Or I would say, forget the patient word, but the person, it's not the end. So it's getting into, you know, you're right, it's blowing up this idea of the diagnostic moment.
And I think this is, if I can take that, just to give the kind of more the formal wrap-up. I mean, this is part of what Eliza, Sam, and Eli's story all have in common. To some degree, they complicate that trajectory. And the notion of this complete transition. They also have very different relationships to and experiences of testosterone in and throughout the transition process that show us something far more complicated. So what does this tell us about the cultural and professional investment in cure and diagnosis in medicine? And I think that kind of key insight of like, part of what it tells us is that there is a particular linearity or time frame or trajectory that medicine has that gets read on through this ideology of cure. Not the only thing.
And it's very clean, right? It's very like wrapped up in a package and put a ribbon on it. And it's not messy. I mean, that's just vulnerability and, you know, health difference, and it's just not wrapped up in a package ever.
Well, I mean, it could be the tyranny of narrative also, right? Whereby it's beginning, middle, and end, always, right?
Yeah.
Like, there's a conclusion, there's a wrap-up, right?
There's a wrap-up.
Yeah.
I'm curious what people think, you know, when I go back to this question, what goal of medicine are we, you know, in service of? And, you know, there's this whole transhumanism movement. So there's an sort of human augmentation or enhancement movement that thinks about in some ways that's what cosmetic surgery has been, right? It's, you know, there are things that are beginning to fall into that category rather than put it in the category of disease, should it be put in terms of transhumanism as a form of human enhancement, that's serving a different goal in medicine? I just wanted to.
Like the cyborg?
Transhumanism is a whole different ball of wax.
Well, it is.
Yeah. But I keep thinking about, you were talking about well-being earlier, and about how the diagnostic codes are only talking about disease, not health. So not well-being, because we know that that term's been commodified. So, but this idea of health, or did someone say human flourishing, right?
Human flourishing, right.
Yeah. So if cobalt blue sky is like human flourishing, and someone is experiencing haze, and or worse, and they need care, medicine's only one aspect of that care. And what's so powerful to me about, at least I'm so much less knowledgeable about this than probably everyone in the room, but just through editing the special issue, the articles that I've read, and the articles I've read to understand how to edit that issue, of articles that were mostly about trans health and diagnosis, is that there's this incredible, what I in that issue named as critical healing or cultural healing dimension, right? That's really evident here. That's coming through the Enriquez, because Eliza was going to blogs to learn how to guide their professionals, right? And their healthcare professionals. And there's such a like, I don't know if we call that out enough, but I feel that for the medical students, you really want to call out that critical or cultural healing dimension, that it's only one part of it. And I'm sorry if this doesn't make sense, but I just feel like this is an opportunity to really bring home that medicine is just one little piece of, as you so well described just now, an ongoing story that mostly doesn't involve healthcare, you know, except as a tool, and a double-edged one.
Or violence, or.
Right.
Yeah. And one of the things that I often talk about with the work that I've done with medical students is that trans people talk to each other about medical experiences to try to prevent additional harm from medical experiences, and try to navigate how do we help each other access the positive parts while avoiding the negative parts, which is not at all how medicine conceives of itself.
Right. No, that's true.
This is our final slide?
Yeah, so which actually kind of gets us into the space where we wanted to be clear. I mean, one of the things that comes from our discussions is, okay, so what do we do with it? This is a bigger picture discussion of narrative and structure and ideology. So what do we do with them? As medical professionals, investments in diagnosis, cure, and treatment, they're built into the practice and logic of medicine itself, independent of what individual practitioners may or may not do within that system. The Disability Studies lens offers one of many tools through which to question the universality of that investment. And I kind of want to come back to Claire and just end with that. That diagnosis can become a cover for what healthcare providers don't understand. They become more important than our messy visceral selves. Become the totality of who we are. And I think just ending with the recognition that that's how diagnosis can function is part of the doing. That critical reflexivity of saying and understanding the power the diagnosis has is part of what you do with the critique that the portrait offers. Thank you.
Thank you.
Thank you.
Thank you, guys. That was beautiful.
So before we start, I want to just take a step to unpack this. I do want to pause and say we could never have had this portrait the way that it is without Shay, who helped us. We were sort of finding narratives, et cetera, and then really we found these two with Shay's help, and this all started from Shay. So
Also, just want to highlight, I found these through my Facebook feed, right? Because I'm friends with other trans people and other queer people who think it's important to share this.
You're
yes,
pointing that way, yeah.
but
Yeah.
thank you.
Even better, right? You got this from the community.
But this is also the point, like, I wonder how we actually make that visible in the portrait itself, because that's kind of a piece.
Yeah.
Like,
Even the medical pieces you got on your Facebook feed from other translators, right?
Yeah, so the two that I had were the New England Journal of Medicine and the microdosing.
Oh, you got the New England Journal of Medicine?
Yeah, so that's interesting too, so finding the part of medicine that.
Well, and it's part of that negotiation, of the sharing of stories to avoid harm in the future, right?
Yeah.
Are you talking about how to highlight, in the narrative, the importance of having that social network to be able to access things? Because there's something in the narrative, in Claire's or something, you might be able to pull that and
Well,
have
certainly
that.
In the Enriquez, Elisa talks about, like their hyperlinks to all the blogs that they
Which are
follow.
great, yeah, they're very good.
Yeah, that's like such a helpful resource, and it's in the LEV. Like, I don't know how much people who teach this are going to read the recommended readings, but it's in the LEV. And I also thought that what you pulled in with the Linton is so perfect for talking about language and really highlighting what disability studies has done to really complicate these categories. And that great thing, I don't know if it was you, Shay, because I can't see everybody, but talking about the way that labels and categories can, people can desire to abolish them, or that they can create community and a sense of belonging, that comes through with the Linton so well.
So we have an hour. So take a break, quick break.
Very quick break.
I have to read.
Do you guys mind if I just say goodbye? Because it's really, there's a lot of ambient sound, and it's really hard to kind of pick out the voices and stuff.
Well, thank you for sticking it out.
We appreciate you being here.
Can I just say, I started thinking about this when I was preparing for this session, because I do think it's just the most incredible portrait. I can't wait to share it. I loved reading the guide. I felt like it's so hard to get these pithy, clear summaries of complicated theory. I felt like you guys did such a good job. I just don't know if there's a thought about like a textbook. How are these going to be made available? Maybe I should already know the answer to that question, but I would also say, I think there could be an amazing critical article that you guys might write spinning out of this discussion, because this discussion was amazing, and it was very effective.
They've got an article right there. Thanks so much, Rebecca. We really appreciate it.
Thank you, Rebecca.
Thank you.
See ya.
Bye.
I actually just got invited to write a
Very good. Thank you. So, some basic questions. Do you think you could teach this portrait? I'm going to put them all out at first. Are all pieces required that we've assigned, especially the required ones? And then we can then move to the suggested. Should we have more of the Eli Claire? Or is that enough? Is the order to your liking? How we moved from a kind of composite or a mixing of the theory in first person to kind of an objective perception of it through medicine to the first person again? So those are kind of our beginning questions. What do you think?
I love the order.
Okay, how come?
First of all, because it's different.
Mm-hmm.
And you're sort of, Laura likes to do this, you go, this. Right?
That could have been where it came from.
And I think it's effective. It's really effective. Now, whether or not I could teach this, I think there would be parts I would feel very comfortable teaching, and then there would be parts that I might be worried I wouldn't be as effective teaching. Maybe not. I don't know. You're like, why not?
No, I'm curious about which one. Yeah, I'm curious about which ones and why.
Tell us more about that.
Well, I think, I feel very comfortable with this sort of naming, disability studies, perspective, the messiness. I think I'm maybe a little bit less knowledgeable about the identity issues. I think I can handle it, but that's a little bit, I would want to feel very responsible for something that is so, I don't know what the word is. It's such a vulnerable kind of, I think all of our pieces are, but it's a vulnerable social theme, right? So
So you would maybe want to have some sort of reading that you could do ahead of time about trans identity that would bulk that up a little bit?
Yeah, maybe. Yeah.
And I was kind of getting to wanting the pronouns like right in front of me, so I don't forget, I was feeling that,
you didn't want to misgender
I didn't want to
people.
misgender people.
And Laura pointed out to me, I was saying they is instead of they are. I mean, it's like, just not even catching that.
I think when you were giving your presentation, I felt you used a number of terms or phrases that were unfamiliar to me that I learned from, but I would not be able to articulate in the same way. So in a way, not that I would want to be highly, overly scripted, but I feel like this is something that if we were to see your script, I feel like I would. Okay.
So would that be
portrait is there?
Yeah, I mean, a lot of what came from the first few slides are the teaching portrait. What's not in there is there are a couple of synthesis slides we added last night. Would that be enough, or you would want actually there was some more work, right? That wasn't
you had a commentary that was not contained within the PowerPoint. I thought that might be helpful. And I think for a lot of people, this is a newer. Yeah, it's a newer theme. A newer topic for further exploration.
I just want to go back to the identity part. I don't think we actually talked about trans identities at all, and I think that's okay, because I think one of the big things that needs to happen in talking about any trans issues, to me, is that I don't really care if you understand what my identity is, but I need you to know better ways to interact with me, and I need you to believe what I'm saying, even if you don't understand it. And in terms of pronouns, I don't think that is not always tied directly to someone's identity. The knowing someone's pronouns doesn't automatically tell you anything about how they identify. And we are using pronouns for everyone that we're talking about, which is why I mentioned, like, if we're, as a practice, we should include pronouns in everything that we're doing. I just want to highlight that there's a separation there, and the goal of this was not actually to understand anyone's identity and how trans identities work and what the possibilities are.
Yeah, I think my sense is that it's more about feeling comfortable understanding a little bit better, like, I don't know how to really describe it, but like for those of us who've read a little bit more deeply in like trans health and understand sort of the range of gender identities and things like that, I think that was my sense of like what you're looking for is like a little bit better understanding of just, no?
I'm kind of interested in the politics of trans identity, right?
Oh.
Well, you know, and so,
I think Shay's point though is kind of important here, which is that like what exactly can we give you that is gonna, you know, because we could go into it on a lot of different levels here that aren't necessarily covered.
I think not having it pinned down would help reinforce the lesson plan, which is that what we're learning from these narratives is that you can't always pin something down and know it, and that there's shifting and changing, and that's part of what the job of the medical practitioner is, to be aware that there's more to the story than it's starting in the room, like you said, the diagnosis, and that the cure, even if there is a cure, or what the patient says they want, isn't always the stopping point. That, and the story doesn't begin, the story begins before. So so that's why I think when you're saying it's not about identity, like pinning down the different identities, that's what I'm hearing, what you're saying. That what's reinforcing the lesson, because my discomfort at using pronouns incorrectly, I think might be a discomfort that students might have in the conversation because they want to use the right pronouns. So I think it's not necessarily that everybody's going to be offended by the wrong pronoun or anything, but it gives a little safety to have the conversation if you feel like, oh, at least I'm using the pronouns that the person wants. Right?
yeah, and for me, the question was, what would I feel comfortable teaching them?
Yeah.
And so what I was trying to articulate is not that we have to know someone's identity, but that, or even that I want a reading, like one reading that's going to give it to me. But that the stuff that I feel more comfortable with, I mean, I think that this is for every portrait, by the way. People say that they don't feel that they could teach, you know, whichever one because of this reason or that reason. So I guess I was just sort of trying to articulate what my comfort zones are for teaching it, that's all.
But I think go ahead, no, go ahead. I heard you.
Perhaps we're going to say the same things, but I think also part of what this portrait is, I think it is unique in some sense that it is going to be taught in a relative vacuum of other conversations about trans healthcare. And correct me if I'm wrong, I mean, this is your area, but I think one of the dangers of, or at least the things that I was most concerned about, speak for myself, in crafting the portrait the way we did, by focusing on, you know, the disability studies analysis of diagnosis and cure, is both, I think it's important that it's not about trans identity because it's a social issue, which is identity, but it's not, but that we're actually opening up space for the conversation to become about fixed identity and to become about preferred pronoun use and to become about classification and identity markers, when the lesson plan is something very, very different, but without the correct tools of the facilitator to know how to say that's not what we're doing, or to feel like they can navigate that. And for students to, I think they're going to fill a gap of wanting to do the right thing, which I think is why that's right. The middle article, the limits of classification, it serves as a kind of key place in the portrait to say it's not about doing the right thing, but that's a nuanced thing to try to teach in a context where there may or may not be other lessons or other contexts where students can talk about trans health. So I think that's the stakes a little bit that I'm like, I don't know.
Can I ask Lily what you think about that? I mean, in terms of students who are going to be entering medical school or in medical school, and this sort of wanting to do the right thing and having it shift back to maybe what the dominant approach is to this topic versus, this much more, complicated.
It's a different angle,
well, I think it's it's a more complicated angle.
Well, that seems to me what it's about too, and then I'll let you speak.
Yeah.
Am
I putting you on the spot?
No, it's fine.
I just would like to get somebody.
And you can speak for all students, right?
I'm not saying that either.
I know, but,
okay.
but I think going back to Shay's point is to think that, I know about identity is back to mastery, right? That I have a sense, and now I know you.
Right.
Right? And that's not what we're talking about, right? This is about ways of engagement, right? That aren't harmful, right? And that could lead to some kind of positive change, right? Am I hearing you right?
Yeah.
So to back off of the identity, right?
Yeah. I could say the same thing about disability identity. Well, let's talk about the disability, though, because I still wonder, most of us have some familiarity with disability studies. Say you're a novice. Say this is your first introduction to a disability studies framework. Is there going to be any potential harm if we don't spend more time unpacking that?
Unpacking identity?
No. Sure. No. Disability and equating it with trans.
Right, so that was my biggest concern with this, and I have been thinking a bit more about whether or not there needs to be a little bit longer intro, and, we had to rush our intro today, but, when we were developing this concept, we were very, very aware that, one of the things that we were saying is that we're using a disability lens. We are not calling trans folks disabled, right? And that was really important. And that one of the reasons we were interested in using this lens is in part because of the overlap between disability studies and queer studies, and how there's really overlapping and important concepts that have come out of it. And Eli Clare was the perfect fit for that in some ways, because he is a disabled, queer, trans scholar. But I think that is an important piece to, at the very least, say from the outset, is that that's exactly our point, is we're not trying to equate these two things at all. We're trying to highlight that disability studies talks about cure. And when you think about trans health and trans folk, they're often put into this framework.
And part of it, and from the beginning, we were trying to make the point that what disability studies does, that lens, is it moves from the gaze being on the individual to society, and that's how we're using it, right? Is to move from the individual and stop thinking in those terms to the structures, right?
So when we think about teaching it, though, did we do enough to lay the groundwork for it? I know it's in the faculty facilitator guide, but is there something else we need to do to frame that?
Really good point.
Let's hear our point, because I feel like people who've not been introduced to it, it wouldn't feel like enough to me.
I agree with, I think incorporating it into the PowerPoint, maybe even in a more explicit way, this is this is the way, you know, that we're using disability studies framework, but this is where it fits as a lens. This is where there's a discontinuity, you know, it doesn't fit as an end, just make that really, really explicit. I think it was in the teaching guide, I'm not sure it came through as much.
Yeah, it was a line or two.
Yeah, it was like a really short
It
paragraph.
was very
like
short,
really
and
short.
I'm not sure it would jump out or resonate with people, and
So I have a question about that, and it occurred to me as we were doing this session. Right now, we're calling this a disability studies framework. Would it be more helpful to just say, using the lens of diagnosis and cure, right? And not calling it disability studies, right? I mean, I think we know that it's disability studies. We can say this comes out of disability studies. But is one of the harms here labeling it disability studies? Is that a potential harm?
so I was sort of curious as I was thinking about this, about, you know, picking disability studies rather than say Foucault.
We could have.
Would they be? I don't think disability studies is always about Foucault.
No, I don't either, but I'm saying you've taken the word disability out of the conversation then, which could be misunderstood unless we spend time unpacking, you know, why we're using disability studies to talk about trans healthcare.
We're using disability studies to talk about the medicalization of trans health.
I get that. I get
And
that.
I think, well, but I hear what you're saying. Sorry, I cut you off.
No, that's okay. I mean, I'm just, I think it's a tricky thing we're doing to be introducing so much
I see what you mean.
nuanced material together where it would be easy for people to get confused about the finer points of the argument.
Do you think that's the same for all of the methods that we're using? I mean, could it be?
Because I think the same thing was being done with like Gretchen's portrait when we learned about, you know, impression management and presentation itself. I mean, that whole portrait had a very rich theoretical framework that was framing it, right? So I wonder if
Way more than you could absorb. I mean,
right.
it's like taking those tiny, tiny little slides from each of these methods.
Yeah,
I
right.
feel like the history was also that as well.
Right.
I don't know how to do that except for, you know, your suggestion of taking out the approach.
So then we spend more time framing the approach in the
You
beginning.
could have a slide that says disability studies does not equal, or disability does not equal.
Is not or something.
I don't know.
Right, and to be more clear about what it is about the disability studies framework that we are using, why we chose it and what we're using, but that it's not because we're trying to equate trans.
With impairment, is that what you're saying? Like, because disability studies is different than disability as
What do
impairment.
you think a medical student who's never even heard the term disability studies? I mean, I think
Yeah, no,
that's where I'm trying to imagine. You're sitting there in a classroom,
Right.
and you're going to think of disability in a medical model sense.
Yeah, you are. Because you're being taught about it.
So part of what we're trying to do
Yeah, no,
is
you're right.
do a couple of complicated
So
things.
that's why I asked, would it be superior, would it be better for us to say, taking the label out, just like we've been talking about the importance of labels, rather than call it the disability studies framing, to really nail down on medicalization, diagnosis, and cure, which we could do.
Well, I'm going to jump in and answer it. Just for me, the logical piece that we'd be missing there is that medicalization and disability studies' understanding of medicalization are not the same.
Right.
That's true.
And the portrait is built by focusing on a disability studies understanding of medicalization. Now, there are ways, I think, we could do that without saying it's a disability studies, but we would say, we would add some more
footnote.
The footnote, but like, I mean, this is my synthesis of disability studies understanding of medicalization. Like, there's no, I mean, we could probably there are probably articles that we could point to and say, this is the disability studies medicalization definition, but it's hard to explain that without
Calling forth the analytic lens.
Yeah, but I mean, it's an interesting thought process, but I think for me, like, not naming it actually takes away specificity of the analytical lens that would mean something very different, at least within the logic of the portrait as it is.
I think it also could potentially take away credit, saying like people have created this field as an academic field,
right,
and have done a lot of work to establish that and to contribute and to also find a sense of identity within that field. And so are we...
So the civil rights piece of it, right, is part of what I think we'd be calling out with the disability studies piece, that there is a normalization of disability as part of the human experience, that people have human rights and civil rights. Would it be helpful to talk just a touch about that history?
I don't think we need to do the entirety of disability studies, though. I think that's where I think what's happening a little bit is that because you know this lens stronger than you have some of the others, we're trying to narrow it down to have it be like really pointy on this particular piece. And we have to because we have 90 minutes, right? But we can't use all of sociology to teach something. I mean, if I was to say we're using a sociological lens, I can't use all of sociology. I can't have the entirety of that field to teach us something. So I think here what we tried to do was we pulled one small portion of disability studies, which was the way that disability studies uses medicalization to analyze these three cases, and two of them really to see like there is in that. So I think it would be slightly problematic to try to pull in all the other pieces too of disability studies, because I mean, if you get this an entire field that you
Help remind me, maybe part of this is my memory. Where do we introduce disability studies in the portrait? At the way beginning.
Yeah, Ali gave a talk a little. Can you go back to that?
Yeah.
Yeah, there's two slides.
Yes, I have a PowerPoint. I think I still have a PowerPoint. Here, they're there.
I have it.
In the teaching, in the
to disability.
it's brief. It's a brief overview. There's
It
three
has to be
slides.
brief. I think if the issue is that,
Okay.
I guess I feel really weird about this because, in two respects. I think if the issue is that we think that there's going to be a slippage between disability and impairment, we just have to say in the slide, we are not talking here about disability as impairment, we're talking about the field of disability studies.
Then you have to explain what impairment is different from disability.
Well, and I think that
well, can I fit, yeah, no, it's okay. And I think that, like what Laura's bringing about, maybe we need to take it out. Well, I don't know where you stand yet.
No, I'm not.
Okay, hold on. If we use something else, to me, it's like, what?
No, nothing, keep going.
It's like, it's the Doug Bainton shit. That's what it is.
Mm-hmm.
It's like being ashamed that, trans people are called disabled by accident and attributed disability. And we should not be ashamed of that.
Some of them are claiming, in the pieces, there's a discussion about claiming or not claiming disability and kind of both sides of that argument, multiple sides in the reading too.
well, and it's also part of, I think, getting into the flip side of medicalization. It's going to be very individual in terms of how people see themselves on the spectrum, of these different language frameworks. But the critical analytic skills is what I felt like I was missing. So when I look at point 1, facilitate knowledge and medicalization through the critical analytic skills disability studies provide. What do we tell students what those critical analytic skills are?
So correct me if I'm wrong, but as I understood it, what we were trying to highlight specifically was the critical analytic skills related to disability studies, understanding, medicalization, diagnosis, and cure. We're really
turning from the individual to society.
and in part, what that helps us to do is to turn from individual to society. I think we're using those particular foci to do that analytic turn from individual to society. But I think we can't do the whole, can't we?
No, I don't think we can either. I just don't want to leave, I'm concerned that if you asked a student at the end of this portrait what disability studies means to them, I'm not sure that they could tell us.
But could you, after any of the portraits, answer that? Then that's my concern, my worry about this. What were the tools of history or performance studies?
So I feel like I actually could do that more than I could with this portrait.
Okay.
Lily, do you want to weigh in? Like, what's your impression of somebody who's going to be a student very soon?
I think Christy makes a good point, because I would be confused as to what disability studies is, and then I think that would affect my understanding of the entire lesson. I also think that Allie brought up a good point that students are going to search for an answer to what is not a question that has an answer, but I'm not really sure how to address that. I think it's important to emphasize that this is like opening the door to a different way of thinking rather than actually providing an answer to.
So you do get it.
Yeah.
Yeah, but maybe coming back to that in a
Reminding at the end.
Or using that language.
Yeah.
Yeah.
Okay, that's helpful.
That's great.
It's helpful. I mean, it's a good point.
Thank you. Sorry if I cut you off, Lily.
And Chrissy, I think your point is really well taken. I mean, I think especially because it's a field that people don't really know as much about. This group is not necessarily going to know as much about. I think it's really key that we don't leave them. They know what history is. You know, they might know about sociology. They maybe don't know anything about disability studies. You don't necessarily want to leave them with like,
I don't
No.
understand psychiatry.
it's
And
true.
we use it to talk about gun violence.
It's true. Well, we use sort of.
Can I do a kind of synthesis of this conversation for our purposes of editing the, I think we are all committed to not taking disability studies out. But the concern is valid of what questions still remain. So how do we operationalize it that takes the focus away from, there is not going to be an understanding of disability studies leaving one 90-minute session. I mean, we have an entire curriculum that teaches students that.
Yeah.
So managing the expectation
Yeah.
and managing, and maybe that involves editing some of the objectives. So that it's less about disability studies analytical tools and more about the analytical tools to critically understand the trajectory of cure, diagnosis, and treatment, or the analytical tools to critically understand medicalization. And then we use disability studies as the framework to do that, but it's not in the objective.
So what if, we never just simply say, disability studies critique the medical model. This is the medical model, this is the social model. There are, to me, that would be a take-home that students could have.
So can I tell you why, and then you can offer? Because I do want to get to the concrete. Here's why I didn't do that.
Okay.
Because it leads, in my experience of teaching this to undergraduates, introducing the medical model, using the language medical model, creates a defensive, devolving digression because they think we're critiquing medicine.
Yeah. Right.
So I deliberately didn't do that in framing medicalization, not outside of the medical social model binary, but because we're critiquing binaries, but I was trying to do an end run around.
I don't think most of these students are actually would be defensive, quite frankly.
I don't know. I mean, when I do a colloquium on medicalization, they're not defensive, but they will talk for a long time about it. And so, and they love it. I mean, they're willing to unpack it. But I think part of the reason we aren't introducing the medical model and all this other stuff is we can talk about these things for a really long time. And just to drop it in their laps and not unpack it, and then to ask them to unpack the other stuff felt unfair to us, I think. So I think what we were trying to do was really just give them like one little chunk that was new for them.
And something that I would just underscore, perhaps even a little bit more in the introduction, is precisely that this is just one aspect of disability.
Just one,
Because I think that there could be a familiar with disability studies, because it's perhaps lesser known than sociology and public theory,
Yeah.
that they walk away and think, oh, I guess that was disability studies, you know, that we just did, so now I guess I understand that framework. Yeah, it's one tool that we're borrowing from.
I hope they don't do that after our portrait, because we're trying to say don't label things and tell people how to hear it. But you're right, it's a good point. Yeah, I think it's a really good point.
I don't know, it's interesting to think about how we get to that clarity that the medical model presents while still allowing us to end run around the digression that comes with presenting it. So I want to think more about it. I want you to know that I know that I jumped in as if I was defensive, and I'm sorry for that.
No.
I'm taking it in.
No, I just wanted to raise it, and I think the portrait is beautiful. It works beautifully for me. I think for people who've got some disability studies background, it's going to be more accessible, though.
Yeah.
And, you know, people don't even know what rehabilitation is, and I'm afraid that disability study, you know, I just think that when you don't teach basics.
Yeah. No, I think what would really be great is we could have a week-long course where we start with, you know, we just have like an introduction to this stuff, right? We really start unpacking. We do a day on medicalization. We do a day on diagnosis. I mean, we could really unpack this and then unfold. We start with the medical model. Like, I think it would be beautiful. We could unpack this in a slow and unfolding way. It would be gorgeous.
Well, and the other question is the teacher, right? So you need to have a teacher that's comfortable with the framework. And
That's what we came across this when we piloted, and several students said, you cannot just have a facilitator who knows nothing about, number one, humanities, or number two, literature, because Michael was teaching Rebecca. And it's totally true. Like, this project is not for just any facilitator. It's okay. I think we first thought it could be, but I don't think to do it responsibly it's going to end up being that way. Yeah. And that's okay. I think that's a limitation of this project, and I'm okay with that. I'd rather it be taught, you know, well.
So these would be available to people who were either in the field or enough adjacent to them that they felt comfortable teaching them.
Yeah.
Well, you know, I can see this actually, the portraits being taken up in the baccalaureate programs,
Yeah.
where they have health humanities programs, right? Because you're going to have an arsenal, a troop of humanities scholars who could pick this stuff up in a way. But it also points out the importance of having humanities faculty at medical schools.
Right. It's not for an MD who doesn't know anything about humanities to drop in and say, I just finished my surgery and, you know, somebody forced me to teach this voluntarily, and I'm just going to, like,
wait, that
you know.
You don't have those, Christy. You don't have those.
No, I mean, it happens all the time, right? Because it's not. The whole point of the project is to show how rigorous humanities is. And
so you're going to have a website. It's going to be publicly available. Will you have all of that, do you think, in the introduction to who should be teaching this?
Yeah.
Okay.
Yes, I think so. And we're not so sure it's going to be publicly available. We're thinking that you have to sort of subscribe in some way, and then you get a password to get access to the portrait. So that was Joanna's idea. I didn't even know you could do that. But so, you know, so that it's not like a free-for-all.
Well, so the AAMC portal,
Medit
portal is where you could potentially get a lot of uptake.
Yeah, you'd have to, it's a publication process, though. You'd have to get them peer-reviewed.
It's peer-reviewed.
Yeah.
It's peer-reviewed, and it's available to any medical school.
That's where
I think that's
our trans-SP case is.
Yeah, that's a good, that's an interesting idea. You know, maybe I should talk.
If you did that, it would be really smart to talk to the editor of that, the Medit portal, because it might be worthwhile thinking of these as a series. Like, you'd want them to be linked if at all possible, so that somebody could go in and download all the portraits, right? Like, you wouldn't want them just to be random, floating around, and so it'd be useful to talk to whoever was an editor to see if there's a possibility to get them.
So then the website would be what? Then it's just a link to Medit portal, or
yeah, that's the one concern I would have about that.
Yeah.
So
I think, I mean, this is a whole other discussion that's not about the portrait.
Right.
You know, I will just add, one of the things that I do think is missing is Charles Rosenberg's framing disease. This guy, I mean, he did this in the 80s. And it's a beautiful chapter.
Do you think that the students need to read that, or do you think that just faculty who are teaching this need to
I don't
read
think
that?
students at all.
You don't?
Well, because they won't read it. I mean, I'm thinking if we're teaching this, I mean, we really worked hard to get these down, right? So that if needed be, you could actually read this
really
in
good.
class, right? You could read it together if you had to.
I know you
Right.
feel very passionate about this.
I feel very passionately about that too. And I will also point out that our scholarly article, we chose very purposely Eli Clare in part because he's trans himself. Like we were very purposeful
I'm not saying, you know, I love the Eli.
No, I'm not saying, I know you don't want us to get rid of it, but I think in part what we were trying also is, as much as the New England Journal of Medicine doesn't have Sam's direct voice, what we also wanted to do was really highlight trans voices too.
And I think that's the historian in you, wanting a brighter world.
It might be. It needs to be on the recommended list.
I agree there.
And,
I agree there.
and you know, you might, it might be a recommended reading
We could maybe even like wave at him in the
maybe wave at him.
But I think the important thing, right, the important thing isn't that they necessarily know who the intellects are behind this, as it is that they can use this language.
and that they get the idea, that they know that the ideas exist.
Because we have to remember this.
I agree with you.
We're helicoptering in.
Yes, I agree.
And we're doing something and helicoptering out.
I agree. No, right.
So we have to
I'm not saying that they need to know Charles Rosenberg.
Right.
But what I'm saying is, I think Eli does probably a more beautifully written job. But he does like mark this out really, really, really well. And in a way that was 30 years ago. So it's
No,
I would recommend that be added to the recommended readings at least.
Okay.
Or, you know, for the facilitator to read.
Great.
I want to poke at another question.
Yeah.
And that is, so for me, one of the big takeaways from this whole portrait is just being attentive to the idea of labels in general, you know, and how lots of it, you don't want to be labeled or put into prefix categories that you just don't fit into. And I know the focus is on trans health, but I feel like it applies in so many other areas of medicine and many patients that they'll encounter. And so I wonder if it would suit the portrait to even ask that question of the students, you know, what other kind of labels do we typically think of in a binary way that you perhaps don't necessarily have to be, and you know, people may not want to be put into those categories. You know, I think, for example, you know, rural or urban or racial categories, or you know, some of these educated, not educated, you know. I think it's hard to sum up the life story by putting somebody in a box, and yet those heuristics are how our brains work, how we navigate the world, but they're not always fair, you know, they don't always do the person justice.
That's a good idea. So it could be a really good, like the wrap up, we could sort of shift into like, how does this apply to other sort of stuff, yeah.
And that happens in research too, right?
Sure.
Maybe that would be back to the lens, right?
Maybe the
This is a way
could
of
be what are the
looking.
benefits and drawbacks of labels, because then it can get to what Shay was saying about the search for a label that was in the articles as well. You know, certain people don't want labels, but in the piece, they kind of find some usefulness in the labels.
And that could also be a really easy way to have students reflect on their own labels and ones that they have embraced and ones that maybe apply to them that they don't like. So I think I always encourage that like self-reflective aspect.
I think also you can embrace certain labels at certain times and not for others, and when you need them and when you don't need them.
Right.
And so,
well, that's also with, I mean, just me sort of getting back to the portrait. But I think that's kind of neat about the classification piece of the New England Journal, that like what we're trying to do is take the label concept and talk about it in terms of diagnosis, but they're all interconnected, like that sort of understanding of labels and diagnosis and all of that. I think the diagnosis concept, I think, troubles, the word I've learned from Allie, troubles the concept of labels sort of in like I had learned of it in a more classification sort of style, and I think diagnosis makes it a more complicated concept. So anyway, I think that's a neat part of what we are trying to build with the portrait.
There's another part about diagnosis I'm going to bring up, but very admittedly, I'm just not an expert in this area, so I can't speak very intelligibly to this, but I know that there are others who can. And that is, I know that there's a scholar who is doing some work at Georgetown, a fellowship on like diagnostic rights. Are you familiar with that territory? And she was speaking of those experiences that people have that are not accounted for in the DSM, and it has shared that those are, if they're not accounted for there, then they're chalked up to being a psychosomatic, right? And not real,
right.
I mean, that are sort of dismissed, and that, I don't know, that might be an interesting area to explore as well. I think she's at the Kennedy Institute at Georgetown. I'm not sure if she's still there, but.
So if we, if I emailed you or something,
There's a coalition for diagnostic rights.
That's probably her, yeah.
I wonder how that sits with like Anna Malo's work on undocumented disabilities, like like trying to not necessarily, like how that might sit outside of the rights framework in relationship, or rights framework versus non-rights framework. Like you have a right to a diagnosis, or you have a right to have an undiagnostic category, stay undiagnostic, and still get care. Like I wonder if I would be super interested to read it, to see if it falls under this rights and justice binary.
Right.
Yeah.
Well, it's also about like what's real, as Erica just said.
Yeah.
And who gets to say what's real?
Yeah. Absolutely. I want to go back to the discussion of the labeling activity though, because in my head I imagined could that work as an opening to then take us through, and then the New England Journal article allows us to reflect back on the labels and then how they get operationalized, or
I just worry that we get there too fast.
Yeah.
To do that.
But what I worry about is if we end, sorry I cut you off. I'm so excited. Please, everybody else, do it. That if we end with a reflection on labels, the takeaway are labels are bad. And then the takeaway with all of taking the point about there's so much material there, in order to make sense of all that material, there's a kind of distillation that I learned all labels are bad.
Well, so I don't think, I think I would want to take Erica's point and make it a little bit more expansive, and rather than just talk about labels, to try to say, how do you reflecting on what we learned today about diagnosis and cure, how does this apply? I think, because I think the label thing will come up in that conversation, hopefully. And if we say it that way, I think that we can think, take what we did, we applied to trans health today, and think about how this also applies to other forms of experiences of identities in the health. Right? Like
this goes on it.
Right. So I think if we frame it that way, that might work.
Go back to the story you told at the beginning.
Right.
So maybe a more helpful take-home message would be, sometimes we have to fit things into labels to be able to achieve the necessary ends. Let's talk about what the range of options are, because would that have felt different to you if the mental health professional had said, okay, I'm going to have to use the diagnostic code, these are the ones I'm thinking about, do any of those resonate more for you, so it wouldn't have been a harm?
It's hard for me to reflect upon that, honestly, at this point. But maybe, right? But that's certainly, I think in terms of an actual activity, it might be useful to make people think through what, again, rather than talking about labels, to really focus on forcing us to think about
So
broadly,
Liza,
like broadly, if we're saying not to think about, I think the example you're giving is still about diagnosis. What I think I was hearing was more about let's apply this to identities, right? Like, let's start thinking about this even more broadly outside of diagnosis. Like, let's think about this in terms of other groups and other.
Like just how we conceptualize.
Folks. Has this shifted your thinking in terms of?
Which is, it's actually
technique.
And also the objective, right? If
Right.
the objective is to critique medicalization and teach, at least in the portrait as it stands now, to understand the ideology of cure. One of the ways the ideology of cure manifests is in shaping how folks relate to their identity in these kind of more rigid ways that are, because it is about normalcy and it is about all of this, but again, I don't know that I'm getting, that might be week 16 of this class.
But then getting back to what Shay's saying is it should not be at all about identity, right? And that,
but it is a little bit.
I don't know
Well,
what
yeah.
you're arguing. I don't want to put words in your mouth, but.
Because I also felt like there's a little concern about someone coming into this without knowing anything about what it means to be trans, and will they get anything out of it? So I think my point was that in what we did today, there was nothing about identity, or about people's trans identities. But do we need some of that?
Well, what do you mean by that? What do you mean there's nothing about people's their trans identity? I mean, we've read 3 pieces about trans identity.
I think it was, though, it was not getting into, like, what does it mean that this person is a trans man? Like, how did they figure it out?
So we didn't explore their identity, like, discovery process, but we did talk about, like, gender binaries and all of those kinds of things. I guess that's where I'm struggling a little bit, is because I think it's about, it sort of depends on what you mean by talking about identity. Because we talk about identity the way I talk about identity, at least in some ways. Like, we definitely explored, to some degree, some of their gender identity. We talked about it with the Claire. We talked about it, we didn't dwell on it with the middle.
Well, we talked about shifting identities and shifting self-concepts and how what one encounters can shift one's thinking about possibilities and futures. But so when we were talking about, trans man identity, it wasn't to learn about trans man identity. It was to learn about how identity shifts and changes and is non-linear and there's not an arrival point. So is that more along with what you were saying?
Okay.
So we weren't studying this material. I mean, this is the same thing we've been trying to do, I think, with all the portraits. Like when we were on the female genital cutting one, or that one we got so distracted because that identity or that experience was so overdetermined that we couldn't focus on what the social theme was. So I feel like this portrait is getting to the social theme without getting into the specifics, which is where it could go, that then we wouldn't be able to draw larger conclusions. And we only have 90 minutes. You hope the larger conclusion is the takeaway.
I think that's a very beautiful observation. I do.
Yeah, I do, that's right.
That was our goal.
Well, but does this portrait help us understand health disparities? When we were talking about Sam, Jay, you brought up, why doesn't Sam have insurance?
Yeah.
Right? So I don't know if do we get to a place where we have a clear understanding of health disparities for trans
We
people?
have the bullet point article of a list of all the different trans health disparities. I wonder if maybe one of the discussion questions could maybe make the connection more.
Circle back to it at the end.
I think that's a really good point, Michael.
Right, we have to come back to, because, well, it was the point,
You're right.
well, we weren't asking that question of this, but it is
It's a good question.
it's a very important question. Why doesn't Sam, because if Sam was still had health insurance, this might not have been the case.
Yes, it would.
Sam would probably still be on testosterone and probably wouldn't be pregnant.
That's probably right, yeah.
Right.
But thank you so much for
Thank you, Christine. I have to say one thing, I've been dying to say it since we were in the last one, but I was trying to wait until I got to the meta. So let's just role play that I'm a person who's taken all of these sessions. I'm the student who has. So one of the things that I wanted to circle back to was the portrait on the in vitro fertilization. It wasn't on in vitro, but the woman who was going to doctor to doctor to doctor and flying to another country.
Oh, yeah.
Yeah, but we dropped that.
What are you talking about?
Yeah, we dropped that, because when Rebecca redid it, she took that out completely.
Oh, yeah, I'm like, what are you talking
No, that was the first time we did it,
the first one.
but that's not in there at all.
So did I, but anyway, okay.
No, I think you're talking about Ellen.
Oh, you are.
I don't remember.
You
You're
are.
talking about Ellen.
Yeah, totally.
The medical.
Yeah, you're talking about Ellen.
Yeah, in that one, there was a whole different attitude, which I kind of took issue with in the group discussion, about the woman who went, had exhausted the number of IVF she could have in the UK, and then she was going to different countries. And I felt like people were kind of dismissing her desire and her comfort and her identity and what harm she would have not being a mother. And these are not at all analogous situations, but I feel like it would be good for us to go back to that one too, and because I felt like the conversation was leading to condemning her.
Oh, interesting.
Because people were, they weren't giving her the same level of compassion as we did for the supposed to say, but it might have been because she was so snarky in the portrait. She was kind of,
she was manipulating.
she was doing the same thing.
Yeah. She was. Right? But it's interesting to think about, like, we just had, Eliza admitted to lying to healthcare practitioners.
Yeah.
Yes, and the response to that, but in a really in a way that is very different, but that's the point. The point is, but it's also a recognition of, like, the structural conditions that shape the lie.
Right.
But I don't know, I wasn't out
when we were looking
But there are structural conditions that shape us.
That's the point.
Because the social theme of that portrait was about the consequences and the identity roles of being a mother in that particular culture.
Yeah.
And so I felt like that got, yeah. So anyway, I don't know, when we go back to it, when we're thinking across them,
To make sure that
to make sure we're kind of not leading to value judgment about certain narratives where we're looking more compassionately at someone's choices, and another one is like, well, she already had all these opportunities. She spent all this money. Why should she go use this other money?
I think that's fabulous.
Yes, a really important point.
And I'm guilty. I had very little sympathy for her.
But I think it's an important piece that some of that is going to be individual. It's going to be something about personality and character, like, and the narrative, right? In some ways, that's how this plays out, is Eliza's narrative is very, endearing. I think there's this, like, the best way to put it. And so it's like, at least that's part of what helps a little bit.
But there were three different stories, three different ways of being a mother in those texts. In Muslim, it was Muslim context.
It was in Morocco.
Morocco.
I really don't remember that portrait at all.
Anyway,
That was a tough
Wonderful to meet you in person.
so happy to actually meet you.
Yes. Thank you, guys.
Wait, we haven't, concluded. Do you want to conclude, or?
Yeah, we're done. It's 5 o'clock.
No, I mean, in terms of your own, what you need, and how you want to just wrap up.
I'm gonna go ahead. Bye, everybody.
Bye-bye.
Two very quick things to maybe address part of that.
Yeah.
One, you need to stick to the framing of disparities in trans health.
I don't want to, personally.
And it be shifting away from using the disparities word, since you don't fully engage with it throughout the entire portrait. So that could be a different way to.
You could drop that. That would be my vote.
You could change
We can.
medicalization.
Sure, great. That would be my vote. I mean, I thought we had to keep it so that we spend some time. Oh, my God.
How do we, on mental illness and, what was it? Something, and he changed it completely. Yeah, race and he changed it to gun violence.
Because he wanted his book to be
We
in
spent
it.
a year and a half trying to find exactly the Latina.
I told you guys it didn't have to be exact months ago. I told
For
you.
that religion.
I did, I told you guys that. It
You're like,
has
oh,
to be
shit,
like,
you got sermon text back.
it has to be
I can be done by now.
You realize how much she is holding herself back from flipping rock right now?
I did.
Yeah.
I did, ask Joanna, I did. But, I mean, you still have to stay within the general realm, you can't just do what Jonathan did. Like, I'm gonna just do something that I've worked on.
The focus was the social theme.
Yes,
And
the
the
focus
social
is
theme.
the social thing.
Right,
But
was
if
on
you
religion.
can't find, I told Joanna, you can choose, if you can't find something on religion, choose some other angle that's about, Latinx, and chronic illness. Or if you can't find chronic illness, then you can do religion, Latinx, and not chronic illness.
Because I feel like we were worried so much about that, and that's why we were having this email conversation where she confirmed that she talked to you and said we can change it, but it wasn't that long ago. So we were still operating under an assumption that we couldn't change it as much, or that it would be the absolute last ditch thing we could do.
No, I explained that a while ago.
Okay.
But I think our book does allow for discussion of health disparities.
You're gonna
No,
decide
you
if you
want
want
to.
to. My feeling is, we aren't, the application is less important in my view. The doing is in the seeing is in the doing, or whatever your statement was.
I think it's I don't think we should leave off the background discussion of the disparities, but the name disparities sets up.
It frames it in the wrong way. Well, and that's why we named it.
You guys can
I think it
understand that.
also
I
kind of
had
limits the
said, like,
possibility of
I
what
know that
trans
this was
healthcare
like
can be.
restricted when you
Yeah,
had to
get it
move the
away from
date.
disparity.
That was the whole point of our,
I
that was the whole
said
point of our
that
discussion
if
at first, was that we
restricted
wanted it to not be
to-
about the traditional disparities.
Something that, work with
Actually be a way of
most.
improving health.
That's what I already said, that
Right.
I'm slightly
Yeah.
concerned about the fact that all three trans perspectives
Are all trans men.
Yep.
Are transmasculine.
Sorry,
Transmasculine.
And also,
and not necessarily
and
trans.
trans, yeah, you're right.
Well, Eliza,
Or sign female at birth.
No,
Got it,
it's,
yeah.
well, we
yeah,
talked a lot about it, we talked a lot about it.
Is that something we should, does it diminish the portrait?
Probably.
I don't know that I would do hard. Yes, I think it can reinforce a lot of what is already happening in trans narratives where people who are assigned female at birth are prioritized in those discussions and have more power.
Okay.
Especially when you, or, I don't know, yeah, I'll just leave it.
Yeah.
No, that's a really good,
One benefit of it is that they were all exploring that their changes differently, so there wasn't just one way.
right, so that was the
So if
benefit
you
of
just
it.
have one of each, then people could assume there's one way to do each.
Right, so that's why
Or three
that was
ways.
why,
Okay.
that was the benefit of the saying, like, they're all sort of dealing with testosterone
So
differently.
it would be something to think about.
There's
when
like
you make changes
pros and
in the
cons,
passing.
I know.
I think that's why we have alternative reading. So if you wanted to do, put in an alternative reading, not the assigned, but the alternative, not the recommended, you could make that, the facilitator could decide, oh, well, I want to do something different, or.
Even more than that, I would highlight the voices that you are, like, name that is what is happening in this.
Yeah.
And say, this is a
We made the choice.
limitation.
This is a limitation, and in
Yeah.
fact, trans women of color, and trans women of color in particular, face these challenges especially, and this limitation of what we do. I think that's a
Right.
really important piece,
And
we
then
just write that down right
And I
now.
think there are also.
Did you send that to us, or no? No, we just said this afterwards, after we put away all our notes.
Yeah, I think the notes that I
Could
will
you?
give you.
That would be.
And I
Yeah,
think
but
there's
it's-
also a
yeah,
piece
just name
that
it.
you can potentially add,
Right.
especially when talking about SAM, in how hormones can impact people differently, and people who take larger doses of testosterone tend to be more likely to eventually pass as men, and that changes how people are reading who they are and what medical care that they need to receive, and it's in many ways harder without additional medical intervention for trans feminine people to pass as trans women, and so that changes how people are reading them, changes what spaces they have access to and what assumptions people are making about their bodies.
Right. I think the piece that Erica pointed out too, that I think is really good to raise too, is the sort of, empathy for the nurse in some ways is also about structure, right? Like, is in part about the reason that that's happening is in part because people haven't learned to just ask that body part, right? Like,
Right, especially when you have the information that trans people are being turned away from health or access to medical care at all.
Right.
I think that's a really important point, Shay, and because we went from diagnosis to cure and missed the treatment.
Yeah.
You talk about that trajectory, but you skip over the treatment. And that gets to the treatment part. And it shows.
Well, see, I guess that's what it is, right, is this is the rub, it's 90 minutes.
It is the rub.
Right?
Right.
And so how do you work within those limitations?
I think it's really.
To present, a portrait that offers some critical thinking.
It's everyone. I think what you do is what people have been saying for pretty much all of these points, and that is just to make it explicit one sentence, and you move on.
Yeah, name it, or draw attention to it and then move away.
What is it called?
Acknowledge it.
When you write, just acknowledge it.
Like a caveat.
A nod. It's a nod.
Like,
and move on.
We won't be doing this and this.
We won't be doing this.
Very strategic reasons that.
We're skipping over treatment, but we know that there's this part of treatment, and it might do this, boom, moving on, cure, or whatever. You know what I'm saying? That's because any class has a limit of 2 hours or 90 minutes. You can't do everything anyway,
It would be interesting to also do some work on thinking about, if you chose to focus on diagnosis, here's some additional questions. So we've laid out 3 trajectories. Our original intent was just to focus on cure, and then I think Rebecca sort of really said, no, you have to talk about diagnosis. Then when we laid the trajectory, it was diagnosis, treatment, cure. So maybe would be some way to build into the portrait to say, these are 3 areas to focus on. You're not going to be able to spend a lot of time on all 3. If you want to expand on the diagnosis, here's where you should focus. If you want to expand on the treatment,
that might be a really nice way.
You can do it that way. You could do it that way, or you could just say, this portrait is, really just focusing on the 2 quote-unquote endpoints, and saying, they aren't endpoints. Either one of them, and, the treatment stuff is,
But
we're tabling that.
No, but you could do Allie's version, which is like a choose your own adventure, right?
Which would then potentially allow us to add in a much more comprehensive and complex picture of first-person narrative.
Yeah.
Yes, although it is more work for you for the revision, and so what I'm saying.
Never mind, no, but
You can put in your, this is really a picture, the one you're teaching.